Good afternoon. My name is Aliyah Abdullah. My colleague David Winters and I have prepared this presentation on optimizing orthopedic surgery at Hipkins Hospital. Our team proposes a set of targeted operational enhancements to improve surgical throughput and patient flow efficiency. We recommend pooling anesthesia and OR resources, hiring 2 CRNAs and 1 PA, reducing to 1 registrar, adding 1 OR to the pool to bring the total to 5, and creating separate OR tracks for patient based on BMI. Additionally, we propose reducing patient arrival times to streamline flow. These changes are projected to increase surgical throughput from 4 to 7 cases per OR per day and reduce patient flow times from between 184 and 200 minutes down to between 139 and 152 minutes. The results? Improved key performance indicators for case volume and patient movement, leading to greater operational efficiency, better patient experience, and higher staff satisfaction. We believe these recommendations are both strategic and achievable, and we look forward to discussing implementation in the next steps. Thank you. Right now, surgeons at Hipkins average 4 to 5 total joint replacements daily, about half the volume seen in private practice. Our target is to increase that to 7 or more surgeries per 10.5-hour day while reducing total patient flow time from arrival to completion. By doing so, we not only improve throughput, but also reduce patient stress, improve family well-being, and increase overall capacity for surgical care. As opposed to surgery itself, surgery workflows function as a batch process, with scheduled patients moving through a series of sequential steps. Our analysis identifies anesthesia delivery and surgery duration as key bottlenecks that limit daily surgical throughput. We're focusing on reducing patient flow time, which measures the full duration from arrival to surgical completion. By streamlining bottlenecks, we aim to lower this time significantly, improving both efficiency and patient experience. In general, in our analysis, we reduce patient flow time from between 184 to 200 minutes to between 139 and 152 minutes, a total of 61 minutes of reduction. Lastly, all proposed changes are being designed with equity in mind, ensuring we support diversity, equity, and inclusion without compromising the quality of care for any patient group. Although we are splitting the patients by BMI, we would take care not to discriminate or affect care delivery based on this factor. This is a table that represents majority of the analysis through which we made recommendations. Looking at scenario A, this is the base case. Scenario B, C, and D represent optimizing utilization, adding 1 CRNA versus 2 CRNAs versus adding 2 CRNAs and a PA. If we look at these columns, we can see that the OR utilization remains high to 90%. This is a bottleneck, and therefore we need to adjust and optimize this. In addition, we can see that adding 2 CRNAs creates a bottleneck in surgeon utilization. So in scenario D, we've added 2 CRNAs and 1 PA, and this effectively optimizes the operating room utilization as well as the surgeon utilization, bringing down the percentages from 90% down to 85% and to 60% for the surgeon's utilization. Next, I looked at pooling, which is scenario E, compared to the base case. When we look at pooling, it doesn't seem to create too much of an effect but it does create a bottleneck within anesthesia. When we look at scenario F, this combines utilization and pooling. And we can see that this allows us to avoid the bottleneck of anesthesia utilization being high. And therefore, it allows us to increase the case number to 6 and 6, and it also brings down utilization across the board. However, this has not reached 7 yet. When we look at variance, moving patients with high BMI to one OR and low BMIs to another OR, it doesn't really show a benefit. However, when we look at combining this with some of the other factors, we do provide a benefit, which we will get to when we go to scenario K. If we look at scenario I, this focused on reducing the patient flow time by increasing the arrival times. And this did show a benefit because it increased it decreased OR utilization significantly. And it decreased patient flow time significantly. However, this effect was not additive when it was added to other scenarios. Instead, we had to decrease the arrival time. And so if we look at scenario K, we effectively decrease the arrival time to 75 minutes. We implemented a combination of these strategy changes to improve efficacy and throughput. First, we reduced patient arrival times to 75 minutes before surgery to streamline flow. We also split patients by BMI into separate OR tracks to reduce variability and delays. We also pooled anesthesia providers and ORs to allow greater scheduling flexibility and resource optimization. We did include a fifth OR as a pool OR. However, this OR was not responsible for its own cases. It was just used for scheduling and for allowing turnover to be easier. I myself am a surgeon, and this is commonly done in real life. In general, the fifth OR is not being built. There are 20, 30 ORs sometimes in a hospital. And so it's really just allocating that OR to the pool of ORs for that service line. And while that does increase some cost utilization, it does not increase that cost utilization significantly. So adding a fifth OR does allow more flexibility. We also did add 2 CRNAs to make it a total of 4 anesthesia providers, and we added 1 PA. We did decide to decrease registrars to only 1 registrar because if you look at the in the table, the registrar pool utilization is very low, 17%, sometimes 15%. And so in general, we felt that it was okay to reallocate that registrar. We did keep the EVS pool the same because it did increase in our scenario K to about 42%, but there is some room there as well. This coordinated approach in scenario K is projected to significantly increase case volumes per OR to 7 cases per day and reduce patient flow times to between 139 minutes and 152 minutes, making the process faster, more efficient, and more patient-centered. This represents one iteration of the analogic model with our recommendations. And as you can see, our patient average flow times range from 139 to 152, and our optimization, our utilizations percentages are within a good range of between 70 to 80%. Next, you'll hear from David with more specifics on each of these details.
This slide focuses on why utilization truly matters and how thoughtful staffing can make or break OR performance. We optimize the use of operating rooms, anesthesia providers, and surgeons, raising their utilization rates to between 70 and 80%, which is a healthy operational target. What's key here is that we didn't simply throw more people at the problem. In fact, we found it unnecessary to add registrars or EVS staff because their utilization stayed low, between 14 and 34%. That insight allowed us to reduce registrar staffing without impacting throughput. Adding 2 CRNAs, however, was another strategic move. It gave us greater flexibility within anesthesia coverage and improved scheduling adaptability. We also saw meaningful improvements by adding 1 OR and pulling resources across all ORs. This not only increased our capacity, but it also shortened patient wait times. Overall, this work highlights the balance we must strike. Overstaffing adds cost without value. Understaffing can create bottlenecks and missed opportunities, so optimizing utilization means aligning the right people in the right roles with the right time and making sure you have flexibility built in. Pooling is one of the most effective strategies for improving operational flexibility, resource efficiency in surgical environments. First, let's look at anesthesiologists. By pooling them across all 5 ORs, rather than assigning them to fixed rooms, we gained the ability to adapt in real time. This model significantly reduced idle time and allowed us to better accommodate variable surgery lengths and unexpected delays, 2 common challenges in OR management. The result, smoother schedules and improved throughput. We also applied the same principle to the operating rooms themselves. Instead of assigning patients or specialties to fixed ORs, we pooled them. This dynamic allocation based on demand helped eliminate bottlenecks, especially during peak times. It meant rooms didn't sit unused while others ran late. In both cases, pooling allowed us to make smarter, faster decisions that improved capacity and reduced inefficiencies. It's a simple shift in structure, but one that had a major impact on performance. Variance is typically viewed as the enemy of efficiency, especially in the operating room. High variability in surgery durations can throw off schedules, cause delays, and lead to underutilized staff and OR time. So at first glance, it seems obvious that reducing variance would help, and it does, but it's not always that simple. Our analysis showed that decreasing variability by just 10 to 20% can meaningfully improve predictability. This makes it easier to tighten scheduling and increase daily surgical volume. However, actually achieving this reduction is complex. It requires managing multiple variables, patient contingents, surgical complexity, staffing, and coordinating between teams. One of the interventions we tested was separating patients by BMI into dedicated OR tracks. On its own, this didn't yield a significant improvement, but when combined with other targeted process improvements, it helped lift our key performance indicators. This highlights an important takeaway. Reducing the impact of variance isn't about just one thing. It's about stacking complementary strategies that align operationally. Small reductions in unpredictability, when scaled across many procedures and days, can add up to meaningful gains. In surgical operations, we often focus on metrics like throughput, turnaround, utilization. It's just as important to consider the psychological experience of patients, their families, and staff too. What we found is that the perception of waiting time can be just as impactful than the actual time spent waiting. Long perceived waits create anxiety, frustration, dissatisfaction, and even the clock can tell a different story. Even if the clock can tell a different story, this affects not only patient and family experience, but also increases pressure on staff who must manage expectations and emotions. We addressed this a few ways. First, we adjusted arrival times to bring patients in faster every 75 minutes instead of larger batch waves. On its own, this didn't just improve flow, it helped psychology. Patients felt like things were moving. When paired with other interventions like improved communication, frequent updates, creating more comfortable waiting environments, we saw measurable improvements in both wait time, metrics, and satisfaction. The key takeaway here is that optimizing operations isn't just a mechanical process, it's a human one. By aligning perceptions with process improvements, we can drive better outcomes across the board. In conclusion, our simulation models revealed powerful insights into how we increase surgical throughput and reduce patient flow times by addressing key operational levers: staffing, OR pooling, variance reduction, and patient experience. These are not isolated improvements, they're part of an integrated approach. By implementing process standardization, reevaluating staffing roles, and continuing to explore pooling strategies, we can enhance efficiency while ensuring equity and care of quality remains central. We also wanted to acknowledge the financial side. Adding an additional OR comes with cost considerations. If the infrastructure already exists, it's a low-cost, high-return move, but constructing a new OR will require a deeper viability assessment. The results are promising. We're projecting an increase in surgeries from 4 to 7 cases per OR per day and a reduction in patient flow time by up to 60 minutes. That's a significant operational gain, and more importantly, it directly improves both staff workflow and patient satisfaction. Next steps would include piloting these changes in phases, monitoring outcomes, adjusting based on real-time data, and considering the financial restrictions. This is how we move Insight to sustain the further impact that we see. Thank you.